Good afternoon, dear colleagues. It's my pleasure to start a short oral discussion session entitled Devising Diabetes Devices. And today we have 8 presentations, and I'm looking forward for the first one, and my pleasure to invite Dr. Bob Ryder from United Kingdom to present on duodenal jejunal bypass liner treatment for type 2 diabetes and obesity, glycemic and CVD risk factor improvements versus risk among 1,068 patients treated worldwide. We have 4 or 5 minutes to each presentation and then for questions, please.
Okay, everybody. I'm Dr. Bob Ryder from Birmingham in the United Kingdom. These are my disclosures, and I'm going to be talking about EndoBarrier. This is an EndoBarrier. Okay, it's a 60 centimeter impermeable sleeve implanted during an endoscopy procedure. Takes about 30 to 45 minutes to get it in, and it's in the position you see here, and it's left in place for up to a year and then taken out. You can see the food passes through it rather than the small intestine, and it's been shown to improve glycemic control and weight in many studies. It mimics the bypass bit of the Roux-en-Y bariatric procedure. Over 3,000 EndoBarriers have been implanted worldwide, and in view of this, in 2017, the Association of British Clinical Diabetologists established a worldwide registry and invited anybody who'd used EndoBarrier in the world to put the data into the registry. And as of April this year, data had been submitted on 1,068 patients from 35 centres in 10 countries. And these are the baseline demographics of those patients. And I point out in particular the mean BMI of 41, and not all of them had diabetes, of course, because it's sometimes being used just for obesity. And this is what happened with the year of EndoBarrier treatment. The weight fell by 13.5 kilograms. There was a reduction in hemoglobin A1C from 67.9 to 54, and there were improvements in systolic blood pressure and cholesterol. However, since not all the patients had diabetes, we looked at the impact on hemoglobin A1C depending on the baseline hemoglobin A1C, and you can see that the higher the baseline hemoglobin A1C, the greater the impact, such that if the hemoglobin A1C was greater than 97 or 11%, it fell by 41.3 or 3.7%. Now, of course, the other question is, what about the serious adverse events of this device? And the answer is the rate was 4.2%. 2.3% were gastrointestinal hemorrhage, and the main one. But the one of greatest interest is the hepatic abscess rate, the liver abscess rate, which is 1.1%. And this is dramatically less than the 3.5% that was reported in the United States pivotal study called ENDO, which is worldwide has caused concerns about EndoBarrier. But we believe this 1.1% is much more near the actual rate of this problem. There were also 13.4% less serious adverse events, but these were sort of relatively minor: early removal because of GI symptoms or migration or liner obstruction, or precautionary hospitalization for symptoms or for an endoscopy. And to give you an example of such a patient, this lady had EndoBarrier removed after 6 months because of pain, and at the explant it was found that the device had migrated. Nevertheless, she experienced considerable benefits from the 6 months with EndoBarrier and would strongly recommend it. And you can see the impact there of hemoglobin A1C dropping from 75 to 47, a big reduction in the requirement for insulin, and weight loss of 19.4 kilograms. And 3 years later, she's maintained the improvement, no longer requires insulin, so this is a success, even though she had this less serious adverse event. So in summary, the mean weight loss during the period of EndoBarrier is 13.5 kilograms, associated with improvements in glycemic control, blood pressure and cholesterol. The greater the hemoglobin A1C at baseline, the bigger the fall. The mean fall of 41.3 or 3.7% if the baseline hemoglobin A1C is greater than 97 or 11%. The rate of serious adverse events was 4.2%. The majority of these were 2.3% were GI bleeds. Early removal of hepatic abscess was 1.1%, noticeably less than the 3.5% rate found in the US pivotal trial. And all the patients with serious adverse events made a full recovery, and most experienced considerable benefit from the treatment despite the adverse events. So in conclusion, the effects of EndoBarrier therapy on glycemic control, weight and blood pressure and cholesterol are likely to reduce the microvascular and macrovascular complications of diabetes, and this international data from our registry suggests that the likely benefits of EndoBarrier treatment outweigh the risks. And just going to go on another second to show you some examples of a couple of patients. So this is a lady before EndoBarrier with a BMI of 33.3, a hemoglobin A1C of 70, and also a raised ALT indicating fatty liver. And this is after 12 months with EndoBarrier. You can see her hemoglobin A1C has come down to 6.8% or 51. She's lost 20.7 kilograms, and the ALT has normalized. And 3 years later, she's maintained this improvement. So this is fatty liver improved. This lady had obstructive sleep apnea requiring continuous positive airway pressure ventilation, wearing a mask overnight. And during the year with EndoBarrier, she lost 21 kilograms. Hemoglobin A1C went down to 43. Her insulin dose dropped considerably, and she no longer required the CPAP, for which she was very grateful. And 2 years later, the improvement continues, and she remains off CPAP. So that's obstructive sleep apnea improved. This lady had impaired renal function, and with the treatment with EndoBarrier, she lost 19.4 kilograms. She no longer required insulin, and her renal function improved. And this improvement was sustained at 24 months. So this is renal function improved. And my last case is a gentleman on 100 units of insulin with a BMI of 35, who after 12 months, his hemoglobin A1C is down to 40 or 5.8%. He's lost 25.6 kilograms, and insulin is no longer required. And a year later, his hemoglobin A1C is actually in the normal range. So that concludes my presentation of EndoBarrier. If any of you want to come and feel it, you're welcome to. And I'll hand back to the chairman.
Okay. Thank you so much for great presentation and great data. Do we have any questions from the audience, please?
So we participated in EndoBarrier in the United States, and we have 2 patients with liver abscess, and the trial was stopped in the United States. I'm wondering why. How do you explain your good outcome compared to what we had in the United States?
I don't know why you had a higher rate of liver abscess in that study, but you can see around the world we didn't. May have just been serendipity. I can tell you now in the new US pivotal study, they are using antibiotics to cover implantation, and they're also doing daily temperature monitoring so that should a liver abscess start to appear, it can be jumped on straight away with antibiotics. And we did have one anecdote of an hepatic abscess in Scotland, actually, in the United Kingdom, who the lady was doing so well, she got an hepatic abscess, and she refused to allow them to take the EndoBarrier out. So she was treated with antibiotics, and it just went away, and she got a whole year of EndoBarrier and a dramatic metabolic improvement. So
what was the total number of patients that you have on EndoBarrier as of now? And what is your weight regain rates? Because you give some examples of the benefit, but what is the total cohort that you've got? What is the weight regain in those populations?
Thank you for the question.
Well, I can only answer that for my own patients. We can't actually prescribe EndoBarrier at the moment because it doesn't have a CE mark, and we hope to get the CE mark back again within the next year. The CE mark was lost in 2017, but up until then we had 62 patients in Birmingham treated with EndoBarrier, and we've tracked them all, And 3 years after removal of the EndoBarrier, 77% of them maintain the improvement. So my view is that it does something to these people. That year of breaking the vicious cycle they've been in of overweight and can't break it, it somehow allows them to break it, and they're so happy with the new themselves that they don't want to lose it again. So that's my experience.
Thank you. And just one quick question for me. Did you have any dietary intervention training for the patient? Because if you have so good follow-up results, and reverse of diabetes, so what was added on?
So very much so. We there is a sort of very strict program for the period of installing the EndoBarrier, because they have to halve their insulin dose if they're on insulin. They have to go on a liquid diet for a week, and then on a soft food diet, and then they must chew their food very thoroughly before swallowing it so it doesn't block. We, in our particular service, we followed them up. We supported them with a weekly phone call in the first month. They had a meeting with the diabetes specialist nurse at a month, and then 3 monthly we continued to see them for the year of EndoBarrier and the year afterwards. And then after that, they were offered follow-up according to their need and desire. Some of them said, I'm fine, I don't need any more help. So in those ones, we said, we'll see you in a year. Some of them we saw more regularly, and they saw a dietitian and to help them. Yeah.
Thank you very much, Dan, for your presentation, and give a big applause for our presenter. Okay, and it's my pleasure to